Case number 5 is a 1-year-old baby who presented with abdominal distension and bloody red current stool. The child was lethargic on physical examination. There was a palpable sausage-shaped abdominal mass, and there was heme-positive stool on rectal exam. His white count was elevated, and CRP was also mildly elevated. Other laboratory investigations were grossly unremarkable. Here we're presented with selected ultrasound images from the case. On the left-hand image, you can see something called the target sign, which consists of this concentric and alternating echogenic bands with hypoechoic bands. In this case, the echogenic band represents the mucosa and muscularis of the bowel wall, and the hypoechoic bands represent the underlying submucosa. And the alternating concentric bands represent an appearance of bowel loops within another bowel loop. Here's the appearance of this in transverse plane. This is something called the pseudo-kidney sign, which is the longitudinal appearance of intussuscepted bowel. This happens when the fat-containing mesentery is dragged into the intussusception, given the appearance of an echogenic appearing renal hilum, or hilum of the kidney. The surrounding edematous bowel wall appears like the renal cortex. So this is a pseudo-kidney sign. This is an example of intussusception, which occurs when one bowel segment is pulled into itself or an adjacent bowel loop. This usually occurs after the first 3 months, with a peak incidence between 6 months to 3 years old. The classic clinical presentation consists of abdominal pain, vomiting, and right upper quadrant sausage-like mass. Sometimes these children will also get red currant jelly stool, which can be a sign of bowel ischemia. Ileocolic intussusception, where a loop of ileum is pulled into the cecum, is the most common due to abundance of lymphoid tissue, which can act as the tissue that pulls the loop of bowel within the terminal ileum. In terms of sonographic appearance, we have already shown the target sign and the pseudokidney sign, which are two imaging signs that shows the classic sonographic appearance of intussusception. With treatment, the most common or the initial modality of treatment is attempted reduction under fluoroscopy. This consists of using water-soluble medium, such as Telebrex or air, which is injected into a rectal tube, and we apply retrograde pressure to attempt to reduce the intussusception. However, reduction is less likely to be successful if there is an associated bowel obstruction, if the symptoms have occurred for greater than 24 hours, or if the patient is lethargic. And in these cases, you can consider surgery if there are protracted symptoms, unsuccessful fluoroscopy reduction, or if there's rectal blood or signs of peritonitis. It's important to keep in mind to always have pediatric surgeon in-house when you're doing a reduction in case you accidentally perforate the bowel due to the applied pressure. Here's what a air enema reduction looks like under fluoroscopy. This is preoperative, intraoperative, and postoperative reduction images. So on the preoperative image, we can see this soft tissue mass at the ileocolic junction, representing the intussuscepted bowel. As we start to attempt to inject air to pressurize this loop of bowel, it starts to reduce, and this soft tissue mass appears smaller. And on the post-reduction images, we can see now air is freely passing from the cecum in a retrograde fashion into the ileum, and these small bowel loops, which were previously not present, have now become air-filled. So this is a case of successful reduction of ileocolic intussusception. This is case number 5, a case of idiocolic intussusception.